All right, guys. Good evening. Good evening. Thank you for kind of joining us, Dr. Chris. Appreciate the good comments there, guys. What I want to share with you as well is Dr. Chris, Derek, Paul, Lauren, Jeff, James. A lot of you guys have known me for a long time, and what Dr. Horn didn't add is that what he did is he got me talking about cases and clinical cases. And once we start about clinical cases, you guys know I can kind of go on and on and on for a long, long time. So that's how we got that seminar going. And so anyway, so that's the fun in all this. So I appreciate you guys kind of joining here tonight. Just to give you a little bit of a real world doing webinars from home in the evenings after you're done with practice is we have a young little kitten here who is destined to climb into my lap and be right here. So you might hear a little purr every now and then, a little meow. So for the most part, I'm getting all the animals fed, but here we are. So adjusting the upper costals. This is a fun topic, and you guys have been around me for a while. You know that this is one of the things we need to take care of, and we must on a regular basis. But many of you may not exactly know the why behind all this. So I want to kind of share with you. We'll get to this next slide. Now, the fun thing about this is that when you have me for a webinar, you pretty much make sure I go through all the slides. If we were having a real live seminar, you know that wouldn't happen. But here we go. So everything starts with a null hypothesis for the most part. And that's the just behind research and really just behind what most of what we do in everyday practice is. Do I think what I'm going to do will have an effect on my patient for good? Because that's what you want, right? You want to have clinical improvement. You want to change patients' lives. You want to help them out. You want to make things better. So way back when, in the late 80s, early 90s, I graduated in 90 and started practicing. Graduated on Saturday, started practicing on Monday. And one of the things that kind of came up is I started doing my orthopedic diplomate, then I started doing my neurology diplomate. And then I remember when we went through and talked about pulmonary physiology, and we talked about vital capacity and forced vital capacity, and that a person should have between 5 to 7 liters. Now, I've been a runner most of my life, and so having, sport tech done and having spirometric values taken was not anything new to me. But I wanted to know if that having subluxation of the ribs would have an effect on forced vital capacity. So long story short, I made that my null hypothesis. Does having chest wall restriction affect pulmonary function? Now, all of you might think that, the answer would be an obvious yes. And to kind of plant seed here, this is kind of how research gets going, right? In other words, we sometimes talk about bias in research, but really all research is biased. In other words, you think something you're doing is going to have an effect, so you want to measure to see if it does, right? And so what I did is I started in practice, and I took 25 patients, 12 females and 13 males, and for 7 consecutive days, the only thing I did was adjust their ribs. Now, if you get into really studying the ribs and you study the dorsal and ventral respiratory nuclei, the pontine, pneumotaxic, and apneustic centers, what you realize is that the upper 6 ribs provide the primary inspiratory drive for respiration. So that's pretty powerful, right? That if you look at your ribs, right? So, and how they kind of break down, that the upper 6 are the ones that are really the most important. Now, you might say, well, the first rib is, and so forth. I'm not really here to argue that. But the idea is that most of your active movement of the ribs takes place in the upper 6. And so if you study large diameter afferent fibers, you study the neurology of facets and so forth, then the idea is that these upper 6 ribs are pretty darn important to human function. And in today's world, if you look at the causes of death kind of around the world, 7 of the top 10 causes of death are considered to be preventable, but also either directly or highly associated with the ability to get oxygen to your brain. So whether you want to talk about hypertension or cancer or diabetes and so forth, there's a relationship here. So what I did is I blinded myself to any symptomatology and got their consent, if you will, measured chest expansion, pulse oximetry, heart rate, and forced vital capacity. So what do you think happened at the end of 7 days? And that included Saturday and Sunday, because I don't believe that we can take off if you're actually doing a research presentation. So after 7 days, right, there was nearly a 3/4 inch increase in chest expansion. there was also a 0.46 liter increase in forced vital capacity. Now, I told yourself that I blinded myself to their symptoms, but I had them complete a neck disability index and an oswestry lumbar score. And so at the end of 7 days, they had nearly a 25% improvement in their scores or a reduction in their pain, however you want to look at it. I also measured urine pH, and there was a consistent shift towards alkalinity in all 25. Now, what does that mean? Well, it means in order to have good rib function, excuse me, that was a cat paw on the keyboard. To have good renal function, your urine pH should closely approximate that of your blood, which is very, very slightly alkaline, 7.37, if you will. Now, if you follow medically, 5 to 8 is considered a normal range. Well, if your urine pH is around 5, you're almost peeing through sheet metal, if you will. So that's too acidic. So we want to have slight alkalinity. So here's the idea. Does alterations of respiration and heart rate affect kidney function? Well, if you follow aldosterone, aldosterone is responsible for blood pressure. That's a measure of kidney function. And here we go. So long story short, as we start kind of building up where we're at today, is we're really kind of establishing the why in this seminar. Why do we need to adjust the upper 6 ribs on nearly every patient? Why are we not just palpating for the tender rib? Because if I hear one more person talk about the tender spot, then Dr. Chris is going to have to contact them, and maybe Dr. Paul as well. So here's the idea. So from a functional perspective, when you start to lose your cervical curve or have any aspects of reduced lordosis or forward head posture, you start to alter the thoracic and costal function biomechanically. Now, sometimes you'll hear the term thoraco-abdominal asynchrony. You may hear the terms diaphragmatic breathing. But either way, when the cervical spine is altered functionally, then you see a downward stream, and it affects how the ribs and the thoracic spine move. And obviously, the ribs are designed to protect the heart and lungs primarily. So a lot was going on here. So therefore, my null hypothesis was proven that chest wall restriction does affect pulmonary function. And then if we get into how we measured chest expansion, and if you're not doing this, I really encourage you to just take a simple cloth measuring tape. And what you're going to do is you're going to measure along T4. And the idea is to have the patient take a little breath, blow out their breath as much as possible, much as possible, mark it, then take the biggest, deepest breath you've ever taken. And so it's going to give you maximal exhalation followed by maximal inhalation, and that would give you your total chest expansion. Now, ideally, you want that to be anywhere between 2.5 to 3 inches. In females, a little bit closer to the 2-inch side. On males, should get closer to the 3-inch side. So what do you think I was finding in practice? Now, admittedly, probably most of us aren't measuring chest expansion. Dr. Rusty, so you want to take the tape around nipple line. So I was trying to show you on this, thank you, sir. In this picture, the viewing left is an incorrect measurement. The viewing right is a correct measurement. So the idea should be taken around T4 nipple line. It should be a straight line all the way around. Thank you, Dr. Rusty, for making that point for me, because I got a little bit off track there. So here's the idea. So knowing that, so the viewing right is your proper procedure. So knowing that you should have this 2.5 to 3 inches of expansion in order to meet your vital capacity. Now, vital capacity is what's necessary for life. And we start measuring your tidal volume or your minute ventilation. These are important factors because a lot of people are living basically hypoxic lives, which what does that mean? That means you're prone for dementia, early neurodegeneration, oxidative stress, early cell death, apoptosis, and a whole host of chronic illnesses. But I'll be honest with you, hardly anybody that I speak to on a regular basis, medical doctors, chiropractors, PTs, DOs, neurologists, and so forth, ever really bring the rib cage into adjustments and what it means functionally. Now, you can go to a spirometry lab or sports lab and have your force vital capacity measured and other measurements, but they're not actually doing anything about your rib cage. And in today's world of forward head posture, of text neck, of slumped posture, and so forth, you would think that this would be a bigger issue. So kudos for you guys for being up tonight. So I'm thankful that you are here. And I'm hoping that we can do more with this and just kind of spread the word out. Dr. Jackie says, I've seen huge improvements in cardiopulmonary function in NICU babies, failure to thrive with upper rib adjustments. Absolutely. And that's what I want to kind of bring out tonight. So thank you so much, Dr. Jackie. I want to bring to you the why we're doing some of this tonight in this topic. Dr. Horn has always asked me to put together some outlines and things. And sometimes he's like, well, would you guys be interested in hearing this? So I hope you are. And so by all means, at the end, kind of let me know. So here's the idea. So chest expansion is one of the things that we measured. And we identify what it should be. Now, here's kind of the question is, what do you think my experience is in clinical practice? Do you think most of your patients are having normal chest expansion, or are most of them grossly decreased? Now, here's kind of how you answer that question. You ask yourself this: what's the percentage of my patients who have a normal cervical alignment? And so that percentage is the same percentage of patients who have normal pulmonary function as well. So long story short is that the majority of your patients have wrecked necks, and they also have very, very poor pulmonary ventilation. Now here's where people get a little bit sideways, is when you have diminished chest expansion, you can still reach by adaptation your pulmonary values, except you do it adversely. So you'll tend to breathe more vertically, right, than A to P or Bell, if you will. So a lot of people are breathing very vertically. And of course, when you breathe vertically, what does that do to your SCMs and your scalenes, as well as your brachial plexus and the whole thoracic outlet and so forth? It creates one chronic mess. But a lot of people don't realize that they're actually not breathing very well, but yet they've got horrible posture, but no one's really doing much about their chest wall. Now, Guyton, way back when, and don't quote me too much, but I want to say probably the 6th edition, it may have been the 5th, but he basically said that the greatest compromise of chest wall, or excuse me, of pulmonary capacity, was chest wall restriction. Well, this sounds like it's right up the chiropractic alley, right? So in other words, subluxation, loss of joint motion. And if you understand that the majority of primary inspiratory drive comes from the upper 6 ribs, then what would it mean to us clinically if those upper 6 ribs were subluxated? That would be a huge loss of input to your pontomedullary centers. And going back to whole brainstem neurology, which I won't do a whole lot of it, that's fairly significant to us as chiropractors. Okay, so we're going to measure chest expansion. So this is how we do that. T4 all the way around, maximum exhalation, followed by maximal inhalation. Measure it, mark it down. So most of my patients don't get more than a ½ inch. So just kind of keep that in mind. I'm not sure what your experience is. I've done several thousands now over the past 30 years. So start playing with that, because chances are, Dr. Chris obviously agrees with me, because if you're doing this, you're seeing what I'm talking about. And that's what I want to try to motivate you guys to do. Just take your cloth tape and measure it, and measure the next 25 patients and see what you find out. Because I'll bet you most of them are not reaching their chest expansion values. And so adjusting the risk can be a very powerful part of correcting and optimizing neurological function. Okay, so here's the next thing here. So I use oximetry. And if you guys follow me, I wrote one of the first papers in oximetry and chiropractic practice back in 2012. And here's what's very interesting about this. Now, you don't have to get a whole lot into the oxyhemoglobin dissociation curve, but if you want to, it's awful fine. If you want to get into the various aspects of anemia and iron binding capacity and so forth, that's great. But here's the idea. So what I want you to think about is, if your oxygen binding or your oxygen availability was diminished, then what would you have to do to your breaths per minute to try to make up for that? The idea is that you would have to breathe at a higher rate. Okay? And this is what people tend to do. So they tend to have an elevated heart rate. So play this game with me just for a second. If you go back into the early 19th century, 40s, 50s, and 60s, the normal breaths per minute was around 6 breaths per minute, 4 to 6 breaths per minute. So kind of hold on to that. If you get into the 80s, then we start saying, well, let's go 6 to 8, maybe 8 to 10 breaths per minute. Absolutely right, Dr. Jackie. Dr. Jackie says, have you seen a lot of anemia in patients that express primary upper chest breathing patterns? Absolutely. I see a ton of it. Too much. Now, as you get into the 90s, we started getting to 8 to 12 breaths per minute. And then here comes the 2000s. 2000s, we started teaching 12 to 16 breaths per minute were normal. And then guess where we are today? Students in chiropractic school today are being taught that 12 to 20 breaths per minute is the normal.